Right, so these are my disclosures. So we have been treating cancers for decades and decades with surgery, chemotherapy, and more recently in the past, targeted therapy were introduced. And now we have immunotherapy, which has completely changed the landscape of treatment. And this is what I'm going to discuss that today, because now we are using immunotherapy in all settings of cancer treatment: neoadjuvant, adjuvant, metastatic first line, metastatic subsequent lines, along with chemotherapy and with radiotherapy also. And for that reason, because it's so effective, when it was discovered first, it was taken by the news in the media quite a lot. And it was said that there's a new era in the war against the cancer. In fact, it was considered as a curative treatment at that time. And because of this, the Professor Allison, who was one of the pioneer of the immune checkpoint inhibitor, was awarded a King Faisal Award here in Riyadh by King Salman in April 2018. And in the same year, they have received a Nobel Prize in October. So they received a prize from Saudi Arabia first, and then a Nobel Prize. Anyhow, to understand the immunotherapy, it's important to understand the cancer immunity cycle, and Dr. Ikram Birni has made a base of that earlier. So I'm not going to go into detail of it, but basically when there's a cancer, it releases antigens which are taken up by the cancer, the dendritic cells or antigen presenting cells, and that takes it to the T cells, which become activated. Those activated T cells then are transported via the blood to the cancer, where it recognizes its antigen, and so the cancer killing happens. This is a very, very brief overview of it, because Dr. Ikram has already explained the mechanism behind it. Currently, the approved antibody immunotherapies are antibody drug conjugates, cancer vaccines, immune checkpoint inhibitors, and other therapies like CAR T-cell therapy and so on. But the most common are the antibody drug conjugates and immune checkpoint inhibitors, which I am going to discuss the evidence behind it. Well, there are hundreds and thousands of trials. I cannot do that, but I'll just give you a very brief overview. Cancer vaccines, again, my colleague Dr. Kram has already discussed. Alfaisal T is the one which is approved currently, and there are few in the melanoma which are currently approved. But antibody drug conjugates are more common along with the immune checkpoint inhibitors. So antibody drug conjugates are created chemically linking antibodies to toxic substances. Currently, the approval are for the enfortumab vedotin in urothelial carcinoma, sacituzumab govitecan in breast cancer and urothelial carcinoma, trastuzumab deruxtecan and TDM1 in a breast cancer. So this is how it looks like. Antibody drug conjugates have three components: antibody, linker, and payload. Payload is basically a cytotoxic agent which is linked through a linker with antibodies. And when it is in the plasma or injected in the plasma, it recognizes its receptor, it gets internalized into the cancer cells, it releases a cytotoxic agent, and that is how apoptosis or cancer killing happens. All the antibody drug conjugates have a targets, like for TDM1 and TDXT, it's a HER2. For sacituzumab govitecan, it's TROP2. So let's discuss the evidence behind it. Currently, there are quite a few trials which led to approval of these antibody drug conjugate. The first one is EV301, which is a study for urothelial carcinoma. So for metastatic urothelial carcinoma, the standard of care for first line is platinum-based chemotherapy, either cisplatin or carboplatin-based chemotherapy if they cannot have cisplatin. In second line, there is no effective treatment, but so far we have been using docetaxel, paclitaxel, vinfluanine. They are not very effective, so there was an unmet need, and this trial has tried to answer that. So in second line, after using the first line or failing the first line, they randomized patient to enfortumab vedotin, which is an antibody drug conjugate, versus chemotherapy alone, and the results were here. Overall survival benefit was seen with the antibody drug conjugate as compared to chemotherapy. Similarly, progression-free survival was significantly better with a hazard ratio of 0.62, favoring use of antibody drug conjugate enfortumab vedotin as compared to chemotherapy in second line. And look at the objective response rate. This is second line urothelial carcinoma. 40.6% as compared to 17.9% with chemotherapy alone, with 5% complete responses reported in this trial from antibody drug conjugate called enfortumab vedotin, and that is why it is now approved in second line after using chemotherapy in first line. Tropic-02 is a study for ER positive, HER2 negative metastatic breast cancer. In first line, we give them CDK4/6 inhibitor with a hormonal treatment. But in the second line, we usually give chemotherapy like capecitabine, vinorelbine, gemcitabine, and eribulin. And this trial have tried to see if immunotherapy is better than second-line chemotherapy. So sacituzumab govitecan was tested against the standard of care, which is chemotherapy. And you can see here, progression-free survival was significantly better with sacituzumab govitecan with a median of 5.5 versus 4 months, has a ratio of 0.6. Similarly, the overall survival with sacituzumab govitecan as compared to chemotherapy in second-line setting was significantly better as compared to chemotherapy alone, with hazard ratio of 0.79. Third study is ASCENT study, which is again a study in metastatic breast cancer, triple-negative breast cancer. We give chemotherapy in first line, and after progression, we give more chemotherapy, but we know this is a very aggressive cancer and responses to chemotherapy are not very effective. So, and that's why this phase 3 study was designed where patients were randomized after failing the first line to either sacituzumab govitecan versus physician choice of chemotherapy. Similar results, progression-free survival, overall survival, and objective response rate were all in favor of using sacituzumab govitecan as compared to chemotherapy. So we know now in second-line setting, urothelial carcinoma, breast cancer, it's better to use immunotherapy using antibody drug conjugates as compared to the standard of care, which used to be chemotherapy. So so we know that it's effective in second line, but is it effective in first line? And this is a study, EV302, a phase 3 study just presented in ESMO Madrid about 2 weeks ago, and I was there actually in this meeting. So as I told you, for metastatic urothelial carcinoma, we use cisplatin-based combination chemotherapy, which is quite toxic. And the idea behind this trial is to use it in first-line metastatic urothelial carcinoma to see if the toxicity would be less and is it as effective or more effective than the standard of care. So the randomization in first line was enfortumab vedotin plus pembrolizumab. Enfortumab vedotin is antibody drug conjugate. Pembrolizumab is immune checkpoint inhibitor or anti-PD-1 antibody versus chemotherapy with the standard is cisplatin or carboplatin with gemcitabine. Overall survival, you can see here significantly better with immunotherapy. EV plus pembrolizumab, median was 31.5 months versus 16.1 for chemotherapy, has a ratio of 0.47. And look at the curves immediately separating, favoring using immunotherapy in first line rather than chemotherapy. Progression-free survival, similar results, median 12.5 versus 6, has a ratio of 0.45. The progression-free survival curve separating immediately and remaining so, favoring using combination of immunotherapy, EV plus pembrolizumab as compared to chemotherapy. And this is the best part of this study. The response rate is 67.7% with 29% complete responses in metastatic urothelial carcinoma, which we usually consider that they have a very bad prognosis and poor survival. With chemotherapy, you can see it was only 44% and 12% complete responses seen in this study. So we are now talking about the immunotherapy taking over the first-line chemotherapy also. We've already discussed that in second line, it's immunotherapy better than chemotherapy, but now most probably it will take over the first line also. So is it better than chemotherapy in terms of side effects? And you can see here with the chemotherapy or cisplatin or carboplatin-based chemotherapies, more anemia, more neutropenia, more thrombocytopenia, and overall also more side effect as compared to when you use 2 drugs of immunotherapy, except a rash was a bit more with the with immunotherapy as compared to the chemotherapy. And the more commonly and the most commonly immunotherapy used are immune checkpoint inhibitors, which we are using in almost all the cancers now. There are 3 different types: anti-CTLA4 inhibitors, PD-1 inhibitors, and PD-L1 inhibitors. And that is the reason these two guys have received a Nobel Prize. So the first and the oldest one is CTLA4 inhibitors. The mechanism is similar. It basically, when the tumor antigen is presented to the T cells, it becomes activated because the tumor cell sends a positive or activating signals. During the same time, you can see in the T cells, there are antigen called CTLA4, cytotoxic T lymphocyte antigen 4. It gets activated and it interacts with receptors on the tumor cells and starts sending negative or inhibitory signals to T cells, which become inactivated. So we don't want that. And that is why if you inhibit or block the CTLA4, the positive signal will continue and T cell will remain activated. Melanoma was the first cancer where it was used. Ipilimumab is the anti-CTLA4, and 2010 was the year where when it was presented in ESCO. There was a standing ovation. The whole hall stood up to clap for the presenter, actually. And the reason is because metastatic melanoma with chemotherapy, 1-year survival is hardly 15%. But when they use ipilimumab, the 1-year survival becomes 46% and 2-year survival of 25%. This is one of the few patients treated earlier who have achieved complete response in melanoma. So as I said, 1-year survival with melanoma or metastatic melanoma was hardly 15% with chemotherapy. But when we started anti-CTLA4, you can see here, the pooled analysis showed 3-year survival of 22% and 7-year overall survival of 17%. So these patients started to live longer and longer. But unfortunately, CTLA4 inhibitors are more toxic. So then the investigators found other ways to block those signaling. So PD-1 or PD-L1 inhibitors were discovered at that time. And same mechanism is when the tumor cells interacts with T cells, it activates the T cell, but at the same time, the receptors on the T cell called programmed death receptors, PD-1, through its ligand PD-L1 interacts with the tumor cell, and it starts sending signaling or negative signaling to stop the T cell activation. But if you block these PD-1 or PD-L1 with antibodies, then this negative or inhibitory signal will not be there, and T cell will remain active. So we have been using PD-1 or PD-L1 inhibitors, and it works very well, but does not cause cure, and the resistance happens. The reason is because there are quite a lot of other signaling pathway where the negatives or inhibitory signals are gone through. The scientists are working on different signaling pathway, and anti-TIGIT is another one which is currently working on it, and we have found the molecule. Hopefully, in the few years' time, you will find another immunotherapy against the anti-TIGIT. Currently, anti-CTLA4 are ipilimumab, tremelimumab most commonly used. Anti-PD-1 are nivolumab, pembrolizumab. Anti-PD-L1 most commonly used are atezolizumab, ipilimumab, durvalumab, and dostarlimab. They are used in melanoma, colorectal cancer, small cell or non-small cell lung cancer, breast cancer, hepatocellular carcinoma, renal cell carcinoma, bladder cancer, endometrial cancer, cervical cancer, almost all the cancer in all the stages. So now we know immunotherapy is effective, but we knew and we've been using chemotherapy for a long, long time. So why not combining both immunotherapy with chemotherapy? Will it be more effective? And it is actually. So it is now a standard of care to use in endometrial cancer, in cervical cancer, lung cancer, and also in urothelial carcinoma. So there are a few trials where I'm going to discuss IMvigor 130, which tried to test atezolizumab with chemotherapy, and Keynote 361 pembrolizumab with chemotherapy. These were negative study, and these combinations were not recommended. But Checkmate 901, which tested nivolumab with chemotherapy versus chemotherapy in metastatic urothelial carcinoma, and the study was presented in ESMO this year, and the study is positive in terms of overall survival, in terms of progression-free survival, and in terms of objective response rate, significantly better when you combine nivolumab with the chemotherapy as compared to chemotherapy alone. Another study in endometrial cancer tried to answer the same thing. If you use in first-line metastatic endometrial cancer pembrolizumab with chemotherapy versus chemotherapy, and they have reported improvement in progression-free survival significantly, and look at the survival curves separating immediately when you combine immunotherapy with chemotherapy. Similarly, the progression-free survival, regardless of the MMR status, the response was seen combining immunotherapy with chemotherapy. Ruby is another study where they used dostarlimab, which is another immune checkpoint inhibitor with chemotherapy in first-line setting metastatic cervix cancer, endometrial cancer versus chemotherapy alone. The results were similar and positive in terms of progression-free survival, in terms of overall survival, favoring using combination of dostarlimab with chemotherapy as compared to chemotherapy alone. Overall survival benefit was also seen. Then we have Keynote 826, metastatic cervical cancer of pembrolizumab with chemotherapy versus chemotherapy alone in first-line setting, and it's now a standard of care actually because of improvement in progression-free survival and overall survival benefits seen when you combine immunotherapy with chemotherapy as compared to chemotherapy alone. So it is better in first-line setting of for cervical and endometrial cancer. Then is it better in neoadjuvant setting? And it has been tested in stage 1B to stage 3A non-small lung cancer, where they combine immunotherapy with chemotherapy versus chemotherapy alone before surgery. And the complete responses or pathological complete responses was much higher when they used chemotherapy with immunotherapy as compared to chemotherapy alone. Similarly, event-free survival was better with the combination as compared to chemotherapy alone. My last few slides is about the combining it with radiotherapy, because it's effective with chemotherapy, but is it effective with radiotherapy also? And there is a rationale behind it, although not much evidence for the combining immunotherapy with radiotherapy. The rationale is when you give radiotherapy, it releases the cancer antigen, and so the cancer immunity cycle gets activated, and so which I've already explained to you. Pacific is a phase 3 study where in stage 3, where the standard of care is concomitant chemoradiotherapy. And after concomitant radiotherapy, they've randomized patient to durvalumab for 12 months versus no treatment. And they have reported that those patients who have durvalumab after radiotherapy, they had a better 5-year progression-free survival as compared to the no treatment. So median of 16.9 months versus 5.6 months, hazard ratio was 0.55. And this benefit was seen in all groups of patients. Similarly, the survival or overall survival was significantly better with durvalumab after radiation as compared to those who did not receive durvalumab, which is immunotherapy, with a median of 47.5 versus 29, hazard ratio of 0.72, favoring using durvalumab rather than giving no treatment after radiotherapy. And this benefit of overall survival was seen in all groups of patients, regardless of age, smoking status, stage of disease, and different tumor histological type. So my last slide is that immunotherapy have changed the treatment landscape for almost all cancers of the patient. It is shown to be effective in neoadjuvant setting, adjuvant setting, first line, and subsequent line setting. It is better in combination with chemotherapy, radiotherapy, and targeted therapy, improving the outcomes in the patient, improving progression-free survival, overall survival, and objective response rate. Unfortunately, we still are trying to get the cure because the resistance happened, and now we are finding more and more target immunotherapy to overcome the resistance and improve the survival of these patients further. Thank you very much.